So Kate, if the situation were somewhat different and there was a risk factor, let's say the patient had encephalitis or something else where you decide the probability of relapse is relatively high, and you want to start someone on a drug, do the guidelines that have been published by the Academy of Neurology or the Epilepsy Society or the International League influence your decision? Do you rely on those guidelines to choose drugs, and what are the advantages you see of that and what are the disadvantages?
Mm-hmm. I think the guidelines are important to keep in mind that we should be following them when we can. They don't fit every patient. I think for physicians like myself that only treat epilepsy patients, our practice, I don't have to think about the guidelines. It's actually how I think mostly in terms of what's the most appropriate medication for a given patient. And as Eric pointed out, we fortunately have many medications now that have less side effects, less drug interactions, are better tolerated, and so it can help guide clinicians in terms of when to pick a medication and what medication to go to.
What are the limitations of the guidelines, though, Trevor, perhaps?
I think guidelines are just what they are, which is guidelines. They're not templates, and although, as Kate's saying, the majority of patients or scenarios fit those guidelines, in a majority of cases, there are patients who fit outside of that bell-shaped curve. And for those patients, the guidelines really are not necessarily appropriate. And it's important to keep that in mind because we have to be able to think laterally under those situations when the guidelines don't fit. And that's but I think if you understand what guidelines are and what guidelines are for, they're important because they provide a framework for us to think. As Kate was saying, I think for those of us in the field, we tend to do it and then look back and say we are following the guidelines because that's the way it is.
Right. And while I'm moderating, I can't resist interjecting one opinion to be a slight curmudgeon, perhaps, in this. But I think it's important to remember that the guidelines are a best practice, but they're based upon clinical trials that are published that have major limitations. So my average patient that I treat in the office does not qualify for any clinical trial. Right? The clinical trials have very specific criteria, and it's a small proportion of my intractable patients who I can put in clinical trials. So the data from the clinical trial used to develop the guidelines already doesn't quite apply, strictly speaking. Secondly, the data is generated by pharmaceutical trials met to meet FDA guidelines, and the big gap there is that the FDA doesn't like comparative trials. They want a drug against placebo, or perhaps a drug against natural history they're now starting to allow. In the world, we're not comparing a drug against placebo. We're comparing, do I choose drug A, B, C, D, E, F, G, et cetera, and we don't have good guidelines really comparing that in this population. And again, patients with major psychiatric problems, patients with significant medical comorbidities, and a variety of conditions just aren't covered. So I think we have to keep in mind that the guidelines are wonderful, but as you said, they're not a template. And certainly, if only 2 companies did studies in elderly people, for example, to assess the efficacy, well, then we only have the highest level of evidence for those 2 drugs. It doesn't mean the other drugs might not be equally good or better, and that's a limitation.